Faysal Saab. We're really lucky to have him here. This is a great talk. I think we were just talking about the fact that I think I've seen this talk 4 times, and I'm still willingly here and happy to be here. I learned something each time. He received both his undergraduate and his MD degree here at UCLA. He also did his residency here in medicine and pediatrics and is now a faculty member in MedPeds. So Bruin for life. I don't think that's ever going to change. um, Wearing his global health hat, Dr. Saab is the Associate Director of the Internal Medicine Global Health Pathway for Residents and has taught and practiced at UCLA partner sites in Lilongwe, Malawi since 2012. So if any of you participate in the 4th year rotation in Malawi, it's a possibility that Dr. Saab will be your preceptor there. You'll be quite lucky if he is. He's completed the Doctors Without Borders Global Health and Humanitarian Medicine program and obtained a diploma in tropical medicine and hygiene. He's also the faculty lead for the Arab Student Organization and leads the DGSOM partnerships with Yarmouk University in Jordan and American University of Beirut in Lebanon. So without further ado, I will pass the mic to Dr. Saab. Thank you so much.
Check. Can you guys hear me? Thanks so much, Tracy. Thanks so much, Saad. Welcome, everyone. I'm pleased to see such great attendance. This is hopefully one of the first kind of talks you receive in global health at UCLA to help you determine if this is something you want to invest in during your time in medical education. So I'm hoping to give you a talk that I never received when I was sitting in your seat. I kind of got into global health for various reasons, but never had a robust understanding of what global health was or the history of it or what my purpose was going forward. So hopefully this can help ground things for you to figure out if this is for you and to understand a little bit more about it. So why should we learn about global health history? Well, we should understand how present global health activities fit into the bigger picture. We have to understand how our own global health engagements fit into the trajectory of the field. We have to refine our own roles and responsibilities, ensure mistakes of the past are not repeated, and have an informed lens through which we view political, economic, and health policies being made on a global scale. And so our objectives today, I hope that we can try and define global health, understand its colonial origins, review the evolution of international health organizations over the past century, understand the impact of World War II on global health, compare vertical versus horizontal approaches to healthcare. If you're not familiar with these terms, super basic terms to know when you're entering the global health literature, reviewing the history of the global primary healthcare movement, comparing where we were then, where we are now, understanding the impact of a little bit of economics on healthcare, and understanding the current landscape and players in global health. And I'd love to engage you all through a couple of think, pair, shares throughout the hour here to try and get your opinions. And in doing so, we're going to be grounding this talk in very seminal cases in global health: yellow fever, cholera, hookworm malaria, smallpox, the Gobi Initiative, which I'll get into later, and HIV and AIDS, cases that help ground very important principles in the practice of global health and where mistakes have been made and hopefully lessons can be learned. Sound good? All right, lots of nods, I like it. So first, think, pair, share. What the heck is global health? Okay, so I get a lot of students, a lot of interns, residents, even faculty members coming to me saying, I'm interested in global health. What should I do? And my answer to them is another question. What do you mean by global health? So if you can chat with your table or with a neighbor for 1 or 2 minutes, and then I'll call on a couple folks to let me to share with the group, how do you define global health? And the answer is there's probably not, well, there are probably some wrong answers, but there are probably few wrong answers because it's kind of undefinable currently. So take a minute. What do you think global health is? And then I'll chime back in a second. I'll just tell them to speak loudly. Yeah, that sounds good. Thank you. All right, I'm going to interrupt and ask for just 2 volunteers, maybe 3, who can be brave and venture a definition. Not all at once. It's tough, right? Did anyone come close? Yes, please.
A great way of thinking about it. I think global health can be thought of as a response to the notion that like viruses, diseases, and health issues don't have borders, and this idea that like the same way our societies may be set up in like organized structures of government, countries, like that's something we've created, and we can actually look at global health as like our own reaction. I feel like we all are trying to solve lots of things.
I love that. Thank you. So in summary, just for the recording, global health is a response to the notion that diseases follow borders, and then figuring out what our charge is in dealing with that kind of history of the way that happened going forward. Thank you so much, both of you, because you were shouted out. Anyone else? Yes, please. Great. Making healthcare affordable everywhere in the world, and where you live should not determine how you live. That's very well said. Thank you. So both correct. Here are several experts in global health defining global health independently. An area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Those health issues that transcend national boundaries and governments and call for actions on the global forces that determine the health of people. Global health is a contested, ethical, political, and technical zone whose contours are still under construction. This person didn't even want to try. A globally shared responsibility to provide health as a public good through an expansive number of initiatives. A little vague. Global health and public health are indistinguishable. This author is saying we just made it up. It's public health. Both view health in terms of physical, mental, and social well-being rather than merely the absence of disease. Both emphasize population-level policies as well as individual approaches to health promotion. Both address the root causes of ill health through a broad array of scientific, social, cultural, and economic strategies. Pretty good. The definition of global health must be rooted in health equity and focus on the collaborative and multidisciplinary nature of global health, with an emphasis on cross-cultural interactions. Global health can't be defined precisely, but several different authoritative bodies have agreed on key elements: equity, global preventive medicine, public health and primary care, cross-cultural sensitivity, and then interaction of medicine and supporting disciplines. For example, anthropology, engineering, admin, agriculture can be used to guide curriculum development. This is all global health. So now you can see that when someone says, Dr. Saab, I'm interested in global health, I'm not quite sure what they mean. And so think about, if you have an interest in the field, is it just going to practice medicine somewhere else? Why? Right? Or is it something structured into other disciplines where you're working with others and delving in that way? Okay, so that's the kind of first bit of food for thought. So let's go to the origins of global health. And we cannot understand global health without understanding colonialism and how that was the root of this all. Right? So the exchange of plants and animals between the Eastern and Western hemispheres during the first transoceanic expeditions to the New World led to high mortality rates. This experience continued for centuries as colonist powers noted that their personnel abroad were succumbing to the varying conditions far from home, and so those resource-rich nations invested in healthcare interventions in resource-deprived nations as part of an effort, not because we cared about other people, but we wanted to improve the working conditions of colonial military personnel, politicians, and workforce abroad. This is the earliest written history of healthcare interventions outside of one's immediate geography. Case 1, yellow fever, Cuba, and the Panama Canal. So in the mid-1700s, the British Army loses 20,000 of their 27,000 soldiers in Cartagena, Colombia, due to yellow fever. And then the French Army suffers a similar fate decades later in the Dominican Republic. And then decades later, they lose even more workers trying to build the Panama Canal, and then that virtually halts the efforts to build the canal, and that was a huge economic project, so people care about money, they start paying attention. And then William Gorgas, who that name might be familiar because there's this famous Gorgas course in tropical medicine named after him. He was appointed chief sanitary officer in Havana, and his objective was go and take out yellow fever and malaria there. So under a US Army commission in Havana, led by the US Surgeon General Walter Reed, which is where presidents go to get treated on the East Coast, confirmed that the yellow fever is caused by Aedes aegypti. And then soon after the Spanish-American War, the US begins its occupation of Cuba. Gorgas declares martial law on all residents of Cuba. And then what happens? Punishment starts giving out, inspection posts, immune, non-immune population separated, guards stationed, water containers destroyed, houses fumigated without consent, staining of fixtures, fabrics, confiscation of personal property, etc. Okay? So then what happens, right? Here's Gorgas. His actions were unilateral, ignored all existing leadership and public health infrastructure. And it was enforced through a cultural construct that subject populations were incapable of taking responsibility for their own health. They needed the United States to come in and say, this is how you do it. And so Gorgas believed that white settlement was necessary for the success of these, quote, uncivilized nations. And so military rule in Havana led to the eradication of yellow fever, good, through vector control practices, but it set a dangerous precedent for American imperialism in the aftermath of World War I and World War II. And we'll get to that a little bit more later. Going back further, colonial medicine had its roots in research as well because it began the first global studies on epidemics. And one of the first studies was that Black people were suited to work in warm climates. And these kinds of studies that you can see here, bar graphs showing the amount of deaths from colonial personnel as you get closer to the equator and warmer climates, that's helped justify the Atlantic slave trade and are one of the origin of the term tropical medicine. Because we need to bring folks that have a certain amount of melanin in their skin because they die less when they work in certain populated areas. And so, of course, the conclusions were erroneous. Relocation of Afro-Caribbean laborers to the Panama Canal suffered the same kind of illnesses. Turned out melanin does not dictate whether or not you die from certain diseases. Randall Packard, who I'll quote a lot, and wrote a book that really inspired me to put this talk together, states, but as many have noted, temperature, humidity, and latitude are rarely, if ever, the sole determinants of the distribution of classical tropical maladies. The history of tropical medicine helps explain why in rich countries the phrase global health connotes diseases of elsewhere, problems affecting an other them rather than an inclusive us. And remarkably, we saw these same themes during COVID. Before it entered our borders here, this was not really an issue the US cared too much about. In 1884, the Berlin Conference decided that, quote, the dark continent of Africa would be divided up fairly among the major European powers, which at that time, Great Britain, Portugal, Germany, and France. And their mission was to, quote, civilize and Christianize the continent. And so colonial medicine then becomes a major focus of these expeditions to protect European, Soviet, and at that time, Japanese empires' imperialistic ambitions abroad. So the international health organizations that, yes, still exist today, they were originally developed in colonial times. You all with me? Trying to connect all these before we arrive to modern day later. Okay, so interventions such as yellow fever eradication, which we saw in Cuba, they were focused on research and investment in biomedical technologies, right? Similar to malaria, we're thinking about vaccines, we're thinking about pesticides, right? Vitamin A deficiency, polio, smallpox. When we think about investing in technologies to get to the problem, these are vertical approaches to healthcare, okay? And as you can see in this chart here, vertical is disease specific, it's cure focused, it's driven by donors or outsiders, and it's not really sustainable without continued funding. Because you can fly in and vaccinate people, but eventually that effect is going to wane. You can fly in and give oral rehydration solution to a kid with diarrhea, and you'll save lives. But eventually the next group of children is gonna get diarrhea, right? You're not addressing any determinants of why these kids are getting recurrent diarrhea. And so it's a resource-rich nation parachuting in to solve a problem, ignoring the larger context of the living conditions of the local population. And in the past 100+ years, billions and billions and billions and billions and billions of dollars have been spent on these vertically oriented programs with little impact on social determinants of health. And for the medical field, those colonial times were an opportunity for experimentation on mankind. Packard states the knowledge and experience gained with those interventions became a library of medicine for the tropics and directly informed the ideas utilized by international health experts and organizations for decades to come, including today. And it was not just the scientific information that was passed along, it was also the attitudes surrounding the science, that the local populations were responsible for their own maladies, were uncivilized, unhygienic, and incapable of addressing their own healthcare needs. So these attitudes get passed on, not just what we learned from the cases. Case 2, cholera and the Philippines. So in 1898 to 1946, the US goes on its next expedition to occupy the Philippines. And sanitary operations there are linked to military operations. Again, the Filipino population was viewed as unsanitary. One officer stated, quote, "They appear to me like so many children who need a strong hand to lead them in the path they are to follow." The Filipino scientist's work was criticized by officials of the colonial administration. In 1902, there was a cholera outbreak in Manila. It killed 200,000 people. And then again, a military-style campaign, war on yellow fever, war on drugs, war on poverty, now war on cholera. It's all kind of a military-style approach to eradicate something. Now we wanted to, quote, sanitize the Filipino body, and a war on cholera is declared. 600 soldiers organized into disinfecting squads. Similar kind of thing with yellow fever in terms of what they imposed on the population. And then when the colonists noted that Filipinos were not getting as sick, they were described as microbial insurrectos and a direct threat to the Americans in the Philippines. So tropical medicine, quote, contributed to the racialized language of the diseased native. Packard states, but even in less explicitly militarized encounters, a moral language of health, hygiene, and the civilizing process suffused colonial discourse and was invoked to justify the continued imperial presence throughout the first half of the 20th century. So in stories, magazine articles, advertisements, non-white colonial subjects were depicted as childlike or worse, part of the local flora and fauna that made the tropics a risky place for white bodies. A talk about the history of global health would be incomplete without mentioning missionary medicine. It started in the early 1800s. These are some famous missionaries, Dr. John Scudder, Dr. David Livingstone, Dr. Peter Parker. And healthcare became an inlet for foreign nationals to enter other nations. Evangelism grew. Mission hospitals and clinics were built worldwide. And at one point, sources state that close to 60% of developing nations' healthcare was actually delivered by Catholic and Protestant missionaries. That's how intertwined healthcare and religion became. And Packard states that for many people in parts of the world, medical missionaries were the sole point of contact with biomedicine. And it revealed that some of the roots of modern global health politics can be traced to the moral economies of missionary medicine. Extended hospital stays were seen as prime opportunities for conversion. Prayer and church services became central parts of the inpatient experience. In short, mission medicine was not done for a purely medical purpose, but used as a beneficent means to spread Christianity. Now, in many parts of the world today, missionary medicine has largely overcome its legacy. Some of my closest and mentors who have inspired me the most are missionary doctors in Malawi, from when I first went there as a medical student in 2012. And they are active in institution building, in investing in communities, in clinical training and sustainability. And there are strong associations published in the literature of the associations between presence of medical missionaries and missionary facilities and gender equality, maternal and child care, and hygiene. So don't go run out of here saying Dr. Saab is giving a big dig on missionary medicine. It's not true. It's just global health started with missionary medicine in a certain lens and approach, and it's transcended much of it, but there are still opportunities for improvement today and areas where it is carried out better than other ways. But missionary medicine has really been crucial in meeting the healthcare gaps in the United Nations Sustainable Development Goals, especially in rural regions. But something to know, okay? Any questions so far? Okay, great. Case 3, hookworm and the Rockefeller Foundation. So Rockefeller Foundation was established in 1913. We're getting to the 1900s, we're getting closer. John D. Rockefeller, right? He wanted to promote the well-being of mankind throughout the world. And actually he had an earnest vision to do this. It was not all self-driven to advance his personal wealth. But the Rockefeller Foundation, we need to know, was the single largest funder of global health efforts in the first half of the 20th century. Who knew, right? I learned about Rockefeller and steel and oil and all that in high school. I had no idea Rockefeller Foundation or himself, he cared about global health. This was the single largest funder. And from 1910 to 1914, the Rockefeller Sanitary Commission for the Eradication of Hookworm Disease becomes prioritized. And they wanted to eliminate hookworm with drugs and shoes and latrines and propaganda. And guess what? Those same people, the same people who had the prior experience in Panama and the Philippines, they were recruited to serve as country directors in the medical field. So when Packard talks about this like pipeline of individuals with expertise, they just went around the world gallivanting, saying, I learned this here, we're gonna do this, replicate, replicate, replicate. And the bureaucrats of the foundation applied this one-size-fits-all technique. In Mexico, the program was pursued despite limited evidence of hookworm prevalence even there. And so again, mandated large population mapping, testing stools, giving out medications that some were fatal and people didn't even have hookworm. So similar patterns. But again, colonial powers made it easy to subjugate the local population to those treatments. So the foundation creates the International Health Board, which focused on addressing hookworm. They really weren't interested in the conditions that made hookworm a public threat: crowding, poverty. They just wanted to treat everyone rather than understand the root cause. The IHB officers didn't understand that shoes were not affordable. Health officers claimed that wearing shoes was a behavioral issue, and the director stated it is the culture and intelligence that causes people to wear shoes. So IHB becomes IHD. Stick with me here, in 1927, and I cannot overstate the extent and duration of the IHD scope because it was vast, significant, and enduring. Massive bureaucracy, staff, and advisory boards in major cities globally, hundreds of in-country offices. They befriended governments. They wanted to tackle disease. They wanted to modernize institutions, and they wanted to promote the importance of public health. So really lots of great initiatives by the International Health Division, and this was all because of Rockefeller. A few important quotes, and the quotes will become less later, I promise. Anna Manuel Byrne, one of my favorite health economists, stated, by the time of its dismantling in 1951, IHD had spent the current day equivalent of billions of dollars on all of these diseases, as well as delimited efforts against even more diseases. In the 93 countries and colonies, they tended to be run with business-like efficiency. Specific interventions were planned with measurable goals and results. It also funded schools of public health, in North America, Europe, Asia, and South America, including Hopkins, Harvard, Toronto, Sao Paulo universities, London School of Hygiene and Tropical Medicine, where I got my diploma, and sponsored 2,500 public health professionals to pursue graduate study. You see the intertwining, okay? And then Packard states that the IHB officers and the authorities and the professionals, they all passed through these same schools, right? Everyone was just kind of in a silo, becoming part of a community of experts who shared a common set of ideas about how to transform the health of people living in colonial and post-colonial settings. And then this process contributed to the further entanglement of colonial medicine and early international health organizations, getting us into more modern times. Any questions? Yes. So he was a true philanthropist, and he had an earnest desire to improve the health of those who were underprivileged. That was, as far as history books tell us, his desire to do that. And then as he grew older and richer, his philanthropic arm went that way. Not much different from, Gates, for example, in the way that he's directed much of his fortune to various approaches to health worldwide. So then in the early 1900s, global health starts evolving, right? In the 1920s, social medicine is on the rise in Europe and Soviet Union. In the 20s and 30s, the Great Depression makes the relationship between health and poverty very clear, right? Those who were chronically poor had documented worse health outcomes and increased need for medical care. And these disease elimination campaigns that produced impressive results were actually short-lived, right? People started to see this. They didn't endure past the colonial control of the target populations. And so then the League of Nations Health Organization in the 1920s begins collaborating with all these other disciplines, thinking about all the definitions of global health: agriculture, International Red Cross, labor organizations. So finally, there's an interdisciplinary discussion about how housing and nutrition and hygiene affects health. This was an absolute first. And discussion of health as a human right led to advocacy to ban gas warfare and other types of weapons. And so in the 30s, this theme of conversations transitions finally to social determinants of health and preventative care. World War II. I had no idea World War II affected global health before, but nothing did more than the war. Why? Because right after World War II, there's a massive focus on funding Europe's reconstruction. And when you have a post-war economy in the United States, what does that look like? Well, decreased wartime production, and you enter an economic recession. Economies, people who have money, love war because it's time for increased production. You got to ramp up your resources there for the war. But then after the war is done, you need new revenue streams to help prop up new economies. And guess what? Africa, Asia, Latin America had tons of nations entering a post-colonial period. And many of those countries became sources of raw materials, and they became new consumer markets. And then there was this rise of development, right? That the, quote, first world wanted to have its economic objectives supported. And so it was vital then for the third world countries to undergo social and economic development so that their resources could be extracted to help fund post-war economies and Europe's reconstruction. So development becomes a major industry, and then experts from the, quote, first world start now to propose policies for modernizing other nations, right? Not because we love to modernize other nations, but because it makes sense for us from an economic standpoint. And then you have a ton of technological advancement at the time, right? Atomic energy is new, DDT, the pesticide used to kill malaria parasites, the Anopheles mosquito, penicillin is discovered, drought-resistant plants. So now we have all these new technologies and everyone gets excited, ooh, what can we do with this? And again, we went back to vertical approaches. But there was a simultaneous, and this is where politics gets intertwined, there's a simultaneous fear of social-based approaches to health because that's what the Soviets were pushing. And so as we got closer to like the Cold War period, everything the Soviets did looked bad to the West and vice versa. And so this brought to mind a Soviet-style approach, and it was rejected by more right-wing politicians worldwide. And so again, getting back into the post-World War II era, there's this era of increased cooperation on issues of universal concern. This was good as well. Look at all the organizations that were created in the world after World War II. All of these in a 5-year period afterwards. UN Relief and Rehab Administration, the World Bank, the IMF, the UN, Food and Agriculture Organization, UNICEF, they launched a TB campaign, the World Health Organization, the UN advocated for a single agency to be responsible for international health cooperation. There was universal membership and decentralization of offices. There was a cholera outbreak in Egypt, and the WHO said, hey, UNICEF is tackling TB, we're gonna tackle cholera, and then they start gaining legitimacy as an advisory and coordinating body. So, you know, out of all that was bad in World War II, and there was plenty to be bad, right after it, the world was coming together for a brief few years and trying to figure out how we can coordinate on health. So then things start getting more politicized, and you can't understand global health without understanding the politics. The WHO was established with a focus on priorities such as clean water and sanitation, which required significant funding from the world's wealthiest nations. But then the funding came with the expectation that health policies would reflect the priorities of the funders. Sound familiar today? Not much is changing. And so when politicians express displeasure with the organization's attempts to set global health policy, funding is reduced. So the Soviet Union accused the WHO of serving American interests and then defunded many of the programs in 1949. We haven't been able to get out of the 40s, and there's already politics complicating this stuff, and now we're defunding important health priorities. And then throughout the Cold War, Europe and the United States start offering technical aid programs like vector disease control to counter Soviet and communist influences in Southeast Asia in exchange for backing pro-Western policies. And we see this pattern repeat itself just a few years ago with COVID vaccine diplomacy, where the United States was eager to use access to vaccines and philanthropic donations of vaccines with a quid pro quo. And the Soviet Union used public health services to illustrate the advantages of community medicine. So then leading us into case 4, which is so important, malaria versus smallpox eradication, a great case to study. So as I mentioned, UNICEF was trying to tackle TB, the WHO tackled cholera, and then the WHO really wanted to take on malaria, despite the science not supporting this as a possibility. But after World War II, pesticide research peaks, eradication is accomplished in the United States, but then demand is dropped because it was eradicated in the US. And so the pesticide manufacturers said, hey, we need more people buying these pesticides, so they lobbied to bring malaria eradication back as a priority, okay? Money, politics, money, politics. So in 1955, the WHO launches their global malaria eradication program. So that's the angle as to why malaria eradication was proposed. And then the Soviets had eradicated smallpox from the Central Asian republics, and I'm going to compare these two efforts in a second. The Soviets had eradicated smallpox, and they wanted to prevent reintroduction of the disease, right? They wanted to protect their borders. So then there started to be this international support for smallpox eradication, but why? It was a way to keep the Soviets on board with international health cooperation. Okay, the Soviets care about smallpox. It's in the Central Asian republics. Let's cooperate on this because we don't want the Soviets to leave the rest of the WHO initiatives. Okay, so we have malaria and we have smallpox, and we're trying to eradicate both of them. What happens? Well, the smallpox eradication program cost $300 million, was successful. Smallpox was eradicated. The malaria eradication program cost $1.4 billion over 14 years. Has malaria been eradicated in 2025? Nope. All right, time for your next think, pair, share. Thinking about what you've learned so far, what are some reasons why these two programs might have had such a terribly different outcome? So spend a minute or two thinking about that, and I'll get some volunteers. Thirty more seconds. All right, if you don't mind wrapping up your conversations, any thoughts on this as to why smallpox eradication was successful and malaria eradication was not and has not been? Yes. So mode of transmission, excellent. What else? Everyone talked about mode of transmission? Okay. Okay, so who was prioritizing it? Who was funding it? What were the resources? Okay. There's a lot of money though, right? They had 4 times, maybe 5 times as much money. Other thoughts? Yeah. Mm-hmm. Horn. Thank you. Yeah, so the idea of addressing the environment and conditions around a disease as well. Excellent. Yes. Mm-hmm. Perfect, right? One has a vaccine. Thank you all so much. So you guys nailed it, right? So malaria eradication, just to fill in some extra details here, was run in a top-down fashion. The protocols for eradication could not be modified as needed by the target nation. It was very much like a, you do this, you do that. Efforts to deviate from the strategies that were not working were discouraged, and the ongoing research was scant. And then mathematical formulas were presented as mosquito elimination strategies to politicians, but regional variations in variables caused errors. And then environmental causes, right? DDT was not effective in houses with mud walls compared to places where folks were housed in other types of structures. And then indoor spraying was not as effective since some populations had a primarily outdoor environment as well. Whereas in smallpox, the protocols were adaptable to target nations. Vaccination was mentioned and case tracking was required. The local program directors had the autonomy to adjust their approach. Surveillance and research programs were robust during elimination campaigns. And so the other key difference, as mentioned, was biology, right? The politicians and funders didn't understand the difference between malaria and smallpox. And I made this table just to think of a few. Malaria could be asymptomatic. Smallpox caused a characteristic rash. Malaria could be transmitted over a long period of time. Smallpox either kills you or creates lifelong immunity. Malaria required repeat community visits for spraying. Mosquitoes became DDT resistant over time due to its use protecting crops from other insects. Smallpox had a 100% effective vaccine and produced a scar that allowed for tracking the vaccinated population, so single visits to communities were enough. So the lessons here are to think of common goals, but be flexible in how local communities apply to them because situations differ. We should not be imposing policies from what's called the global north without reanalysis of efficacy. The biology of a disease has to be considered. Disease elimination campaigns can be massively funded, right? More than 4x with malaria compared to smallpox, and still fail if your proper variables aren't being considered. And then alternatives to vertical approaches, right? Addressing sanitation, draining swamps and stagnant water, access to clean water, addressing poverty, public health, education, community infrastructure could actually be much more economical, effective, and sustainable. These lessons are so applicable to any type of global health research that all of us might engage in during our careers. Okay, moving into the primary healthcare movement. So now we're in the 1970s, getting closer. The WHO director, Hofton Mahler, states, quote, "The most signal failure of the WHO as well as member states has undoubtedly been their inability to promote the development of basic health services and to improve their coverage and utilization." This guy was a standout. The WHO hadn't had a leader like him yet. He called upon member states to create community-based health systems with cost-effective, scientifically grounded initiatives. And in 1978, a conference I had never heard of before, the Alma-Ata Conference, attracted 3,000 delegates, 134 governments, 67 international organizations, and met for 7 days in Alma-Ata, Kazakhstan. What do? They put together this 10-statement declaration on primary health care. And just to highlight a few things, they wanted to reaffirm that health is a fundamental human right. Guess where we keep hearing that, right? The attainment of the highest possible health requires the action of many other social and economic sectors. There is gross inequality in the health status. It's unacceptable. Economic and social development is basic importance. The people have a right and duty to participate in the planning of their healthcare. The governments have a responsibility for the health of their people, and primary healthcare is key to attaining that. Primary healthcare is essential healthcare based on practical, scientifically sound, and social acceptable methods. All governments should launch and sustain primary healthcare as part of their system. All countries should cooperate. And number 10, my favorite, an acceptable level of health for all people of the world by the year 2000 can be attained through a fuller and better use of the world's resources, a considerable part of which is now spent on armaments and military conflicts. So it's amazing and sad, I read this, 50 years ago, how all of these countries came together and agreed about the importance of primary healthcare and agreed about how if you invest kind of at the core in health systems, perhaps all people of the world can have the healthcare they deserve. and this principle that governments should be able to provide for their people. All of these are struggling to survive in this current era. So what happens, right? The primary healthcare movement, PHC, ultimately fails because it was ambiguous. It didn't detail who was going to finance it or scale it up. And so the lack of investment ensued. Why? Because it wasn't really quick in its impact or dramatic as a headline maker, right? Changes are subtle and slow, right? Bill Gates would rather invest in one drug that eradicates something than say, let's build up health clinics and in 40 years do an analysis of what that did for the population of a country, right? They're not headline grabbing things that large donors often want their names on, and that's why vertical programs have been prioritized so much, and that's where still a lot of the money goes to disproportionately today. We're doing better, but not quite there yet. So a year later, the Rockefeller Foundation, yep, still exists. They meet in Bellagio, Italy, and they change it essentially to this principle that Judith Walsh and Kenneth Warren, health economists, published in NEJM, selective primary healthcare, right? An interim strategy for disease control. They understood that primary healthcare was important. They didn't really think it was reasonable or attainable, so we're going to select. And so PHC becomes selective primary healthcare, and they wanted to focus on GOBI. GOBI is, in the PEDS literature, frequently mentioned, and it's growth oral rehydration solutions, breastfeeding, and immunizations. And it is a vertical program created by UNICEF disguised as primary healthcare. I'm not saying it's not great to encourage breastfeeding and immunizations, but again, these are ways to parachute in, say, do this right now, but you're not really empowering or allowing people to be capable to have the nutrition needed to breastfeed. And ignores leading causes of death in resource-deprived nations such as pneumonia. And so Rockefeller, though, gets behind selective primary healthcare. The World Bank felt like it was appealing. The health economists were saying it makes sense. But then Hofmann-Mahler in the WHO says, you know what, we're still going to endorse primary healthcare. All right, so then second to last, I believe, case study, UNICEF and the GOBI campaign. This guy's important to know as well. This is James Grant. James Grant was the executive director of UNICEF. And he was known for his super charismatic leadership, right? He had the ability to attract donors like none other. Paul Farmer himself stated, Grant cajoled and persuaded and flattered and shamed and praised and eventually generated more political capital for the child survival revolution than anyone at UNICEF had believed possible. After the '84 Bellagio conference, the Task Force for Child Survival, composed of UNICEF, the Rockefeller Foundation, WHO, UNDP, and the World Bank, declares immunization as the most important of the GOBI interventions. And so then UNICEF spears these national immunization days. Clinics, health providers, and support teams from the UNICEF and the WHO participate. They wanted to reduce child mortality by 50%, raising immunization rates to 80% in developing countries. And guess what? They did it. They met their target in 1990. Something truly amazing happened. Can't be that amazing, right? Because I'm including it in the slides. So 1995, James Grant dies. UNICEF is unable to sustain its gains afterwards. And in 2008, the State of the World's Children's Report noted that 26,000 children under the age of 5 were still dying each day in developing countries. Quote, the problem of infant mortality is no less poignant today than it was 25 years ago when the child survival revolution was launched. Why? What happened? Think with each other for a minute, and I'll get a couple more volunteers to share. Right? The question is, why can't UNICEF sustain its momentum and its gains afterwards? All right, 10 more seconds. This one's a little shorter. All right, let's bring it back. Couple thoughts from the group. What happened? Yeah.
This was a very required a lot of funding for this initiative. It never actually went in fully addressed the root causes to why there was a big child poverty issue in these countries. And so when James Grant died and he wasn't bringing in all that funding anymore, he really started to see the underlying cause again.
Wonderful. Thank you so much. So just for the recording of those who couldn't hear, once James Grant dies and he's the funder and kind of cajoling donors all over the world, it's hard to sustain. And none of this was a horizontal approach. It was more vertically oriented, right? Thank you. Any thoughts different than that? Your table nailed it. All right. Thank you. So, right, the campaign had a minimal impact on health systems, right? And without bolstering public health infrastructure, workforce, supply chains, or the provision of primary care services, Gobi did little to strengthen health systems or improve health indicators other than infant mortality. In other words, the campaign's successes, though significant, right? It's good to save lives, they weren't sustainable. So the lesson is celebrating the transient success of a vertically oriented program, but over decades, the gains are very modest. We can provide ORS, right, oral rehydration solution en masse to developing nations, but unless we understand address the problem of clean water and sanitation, these campaigns are just Band-Aids. Are they still good? Sure, but you can have a lot more bang for buck if you truly understand global health and social determinants of health by convincing folks to do it the right way. And then Paul Farmer, well, in 2006, UNICEF itself called Gobi a throwback to the mass anti-disease campaigns of the 1950s. And then the last thing is that these initiatives were set by the UN instead of by the target nations leadership who better understood their own epidemiology, culture, geography, and health systems, okay? In his book, which one was it? Reimagining Global Health, Farmer talks about this, the impact of one super enthusiastic, energetic figure and what that can do for a movement, but how we have to rethink whether or not that's the best way to get behind something, because we should follow a principle, not a person. So then getting into more modern times, right, the landscape of global health changes. In '93, the World Bank Development Report, Investing in Health, showed that suspending on health can be justified on purely economic grounds. Now we finally see in the '90s this rise of privatization of healthcare. Governments, quote, cannot and should not provide for the health of their citizens. This is just 20 years after Alma-Ata, right? And there's this language of, well, people should just do it on their own. If they can pay, they can get healthcare. And this neoliberal approach to healthcare financing started rising. They promoted user fees, increased reliance on NGOs in the private sector. And then just look at how the landscape changes, because in 1970, the World Bank had put out one loan for like health-oriented projects, and that was less than 1% of its investments. In 1997, a quarter of the World Bank's investments were focused on health. And by the early 2000s, the World Bank has now become the largest funder of global health programs. So 1900s, Rockefeller. 2000s, World Bank. They partnered with WHO, UNICEF, and UNAIDS. And then as we got a couple decades into today, other organizations become massive funders as well. But by 2013, the World Bank had funded 65,000 civil society initiations in sub-Saharan Africa with $4.6 billion for HIV/AIDS, right? And again, great things. The World Bank has done a lot of good for our world. But then you also have this rise of NGO-based healthcare delivery, right? Because the World Bank is usually sending funds and signing contracts with a lot of private kind of players here and NGOs. And so a lot of these logos are ones that you might recognize, really great, outstanding NGOs. The other thing I don't want you to do is run out of here saying Dr. Saab was giving a dig on all the NGOs in the world as well. It's not what I'm doing. It's just that neoliberalism advocated for decreased cooperation with governments. They said governments is the wrong way to go. Donors were concerned about the UN and WHO agencies because of political influence and bureaucratic inefficiencies, and they weren't wrong, right? We saw what would happen when there was political disagreement about a healthcare priority and how something could be massively defunded quickly if the Soviet Union and the US at that time disagreed. And so everyone just got excited and they're like, forget the governments, we're gonna go the NGO route. And so there's a true rise in this, right? From 1980 to 2006, look what happens to the number of NGOs linked to UN agencies, right? The 2006 number isn't even including local NGOs. But then Farmer and his colleagues stated, but no private entity can meet the whole range of interlocking needs of a system to support healthy human lives. And no NGO is capable of conferring rights to those in need of them. NGOs can at most establish a provider-client relation within a framework of legal rights that only a state can confer, right? So you go into a country, you want to found an NGO, looks good on the CV and the resume, you want to volunteer. Well, that's great. Understand that if we want to change things for a long time, we need to work with existing infrastructure and figure out how to build it up. Because NGOs, as good as many of them are, often work in silos. In places like Malawi, I know that there are tons of NGOs doing the same thing. And they may not even know that the other exists. And so communication is fragmented, funding is fragmented, and the efforts aren't streamlined whatsoever. And maybe that's just the way it needs to be because critics will say, well, the Malawian government can't be trusted. We sent millions of dollars for COVID response. It disappeared overnight. Other countries had the same experience. I'm not at all saying that corruption doesn't exist. These are just challenges in the way global health is delivered today and things that need a lot of practical thought in the way that we figure out how we can best address them. But that's how the landscape changes, right? And as it changes, you have a slew of other massive organizations that get formed. So then Global Alliance for Vaccines and Immunizations, Bill and Melinda Gates started with 200 million, now close to $50 billion in assets. The Global Fund to fight AIDS, TB, and malaria. The PEPFAR plan, which had bipartisan support for a couple of decades now and now no longer does, did a ton for AIDS relief. These were new massively funded organizations that were internally accountable. They prioritized evidence-based interventions, which is great, and they focused on RCTs, but again, they prioritized vertical campaigns. Again, they focused on biomed technologies, disease elimination, and then it was more complicated to create an RCT about the benefits of community-based primary care healthcare systems than it is to you get a vaccine, you don't, you get whatever you don't, right? So, and then they continued to hold these large forums on disease eradication without the primary stakeholders in target nations, right? Gates's malaria forum in 2007 was held in Seattle. So just the lack of understanding of how we include partners who are actually dealing with the brunt of disease. Okay, questions so far? This is the last case. Okay, so the AIDS epidemic, advocacy, money, and the Global Fund. So in '96, HART gets created, right? HART is highly active antiretroviral therapy, 3 antiviral medications in 1 pill that are highly effective in suppressing HIV load. And we know that when we are undetectable in our viral load, we are essentially untransmissible. So it was as close to a cure that was going to exist. And it reduced AIDS mortality by 46%. Mortality continued to climb in resource-deprived nations with no highly active antiretroviral therapy. The attitude in the global north was that HART would not work in the global south. And the head of USAID in his testimony to the House of Representatives said, if we had them today, we could not distribute them. We could not administer the program because we do not have the doctors, we do not have the roads, we do not have the cold chain. If you have traveled to rural Africa, you know this. This is not a criticism, just a different world. People do not know what watches and clocks are. They do not use Western means for telling time. I've traveled to these villages, and if someone doesn't have a watch, it does not mean they don't know what time it is. When we distribute medications to folks in villages, oftentimes the pack of medication will have a sunrise on one of them, a sun at the top in the second one, right? And then a sun setting in the third one. It just shows that there was lack of investment in understanding the issues and trying to essentially give a testimony that seemed very easy for American politicians to understand and say, we really want to do this, our heart's in the right place, but they can't do it, right? This pervasive attitude about individuals who live in places that others don't understand or have not visited. So at that time, HART cost $15,000 per patient per year. And these generic low-cost alternatives, they were being blocked by property rights agreements. And in 1997, South Africa passes a Medicines and Related Substances Control Amendment Act to lower the cost of heart and improve access to quality HIV care. They challenged property rights agreements, and then Big Pharma comes and sued South Africa for rights agreements, for rights infringements. And then the US government backed Big Pharma in the lawsuits. And so for 3 more years, right, when thousands and thousands and thousands of people are dying from AIDS, there's absolutely no progress on heart in the global South. And then in 2000, in the International AIDS Conference in South Africa, which is pictured here, AIDS activists organized a massive protest calling for improved heart access. The US Congress's Black Caucus pressures the Clinton administration to remove its backing of the lawsuit. And then right after, heart was placed on generic track, and by 2007, the cost was brought down from $15,000 to $87 per person, which is remarkable, right? They weren't asking folks in rural sub-Saharan to pay $87 because that was unaffordable often. But for a funder, how many people can you treat for $87 per person compared to $15,000? This was absolutely transformational. It's probably one of my favorite examples of what advocacy can do and how the intertwining of politics and protest and advocacy, what it can do to actually save lives. In 2000, the G8 summit meets, and so they promised to provide funds to address HIV, malaria, and TB. Jeffrey Sachs, a renowned health economist, reported that health outcomes could boost economic growth. Amir Adaran, a famous Canadian health economist, reported that new funding targeting infectious diseases killers is cost effective. And then in 2001, Kofi Annan, who was then the Secretary General of the United Nations, called for a $10 billion fund to fight HIV, malaria, and TB, and that's how the Global Fund got created. The full name is Global Fund to Fight AIDS, TB, and Malaria. Now it's just known as the Global Fund. And by 2022, it had a posted $65 billion in contributions so far. So why am I mentioning it? Maybe there's a bit of a downside. Yes, this is all great, but are there lessons here? At its rollout, there was a limited time for countries to respond to call for proposals. The country ownership wasn't always respected, and the NGOs, again, were given priority over governments. Guidance still needed to be sought from the WHO and UNICEF, the Global North. And the majority of grants were focused on purchasing commodities, even though those commodities could not be delivered on the ground sometimes. And so the grants contributed from the Global Fund to medicalization and commodification of global health. So even in solidly into the 2000s, these mistakes from the 1900s get repeated. And so as we kind of wrap up here, and I really want to take your questions, this is just an overview from one of my colleagues, Dr. Aya Fani, thinking about the terminology. Back when I asked you what is global health and what does that all really mean, the term is new, right? It kind of all started again in colonial rule and the slave trade, in colonial medicine, medical care to colonial officers as they established colonial rule and transatlantic slave trade, and then missionary medicine enters as a means to facilitate civilization and conversion. And then tropical medicine starts applying germ theory and new scientific concepts to achieve disease control in the colonies. And then going to the 1900s, you have this boon of international health organizations to coordinate disease control across borders. The schools of public health and tropical medicine get funded by Rockefeller, and then organizations get created post-World War II. And then it only started getting called global health like in the past 25 years. And maybe a little more, but it's a very recent phenomenon, this change in terminology. And right now, as best we can understand it, right, it's an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. But as you saw, there are many other definitions. And so today's global health players, you have the Gates Foundation, the Global Fund, the World Bank Group, the WHO, the USAID, UNAIDS. I guess I should take PEPFAR down now. UNICEF, Médecins Sans Frontières, which is Doctors Without Borders, and Partners in Health, which is the late Dr. Paul Farmer's organization. His book with colleagues has a couple of quotes that I'm going to leave you with that are some of my favorites. The second one's my favorite, but we'll start with this first one. Some healthcare providers learned to use vertical AIDS programs to simultaneously provide horizontal primary healthcare services and strengthen health systems. Health practitioners, including community health workers who are focusing on HIV control, can be trained to simultaneously address other pathologies of poverty. HIV patients infected with TB, children with pneumonia or diarrheal disease, families without sufficient food or access to clean water. In other words, AIDS treatment can be used as a wedge to strengthen health systems, right? So folks practicing global health are saying, you know what, we see all these vertical approaches getting funded. Can we take that money for the vertical approaches and essentially use it to provide horizontal approaches in healthcare, right? Can we leverage that? And as an example, in the clinic that we partner with in Lilongwe, Malawi, there were massive funds and grants for HIV care. And there was something called Option B Plus that essentially showed that women who were HIV positive, if they started HAART therapy right away, they would decrease transmission to the infant. So you'd have decreased MTCT, so maternal to child transmission. And keeping the woman on it lifelong would reduce transmission via things like breastfeeding and other interactions with the child as well. And so you have the funding for HIV care for these women right away. So all the women from the villages started coming to our clinics and clinics around the country because they wanted to get HIV care. And that's where the money was. But guess what? We could also screen for hypertension and diabetes and ask them if they want to engage in family planning and ask them about XYZ, right? And so this is what Farmer and colleagues are talking about when you can leverage vertical care to provide horizontal care. And AIDS control is a great way that folks started doing that in the global health one. Okay, last one. A biosocial approach demands the reconciliation and occasional disruption of multiple frames of knowledge. A medical student will learn, for instance, that the cause of cerebral malaria is the protozoa Plasmodium falciparum, and that the treatments of choice include quinine and artemisinin-based combination therapy. Whereas an epidemiologist or public health planner might view the cause as undrained breeding grounds for the mosquito vector and recommend draining standing water, providing mosquito nets, and spraying DDT. All the while, residents of an endemic area and ethnographers who speak with them might assert that the cause of malaria is the unequal distribution of land under the local system of tenancy and might protest that DDT's environmental effects make its use unacceptable. You see how your positionality totally changes your approach to global health. And that's why whatever definition we want to accept, it must include a cognizance that this is an multidisciplinary field, right? That if we as doctors aren't working with experts in food and agriculture, aren't working with experts in labor, in land rights, with economists, with politicians, we can fly in and spray all the DDT that we want, right? We can go in and try to give everybody prophylaxis. But from each perspective, people are going to feel like the cause is not being addressed. And we need to honor those perspectives to figure out what the most effective route is. So what are our takeaways? The definition of global health continues to evolve. Global health is rooted in colonial practices. The prior history continues to affect the field today. I hope I've convinced you that economic policies and donor priorities have a massive impact on global health, that vertical approaches continue to dominate the field today, that NGOs remain the preferential mechanism for funneling resources into resource-deprived settings, and that decisions on the health of people in resource-deprived countries continue to be made today by individuals and organizations in resource-rich nations. What does this mean? Questions to ask yourself and your program. I highly recommend you take a picture of this slide. If you ever think you're going to be engaged in anything global health related, these are questions that will apply. If you've done anything global health related in the past, how does applying this historical lens change the way you think about that engagement? Would you have done anything differently? Any lessons learned or challenges faced that are similar to those shared today? I know that I had those reflections a lot. I had some tough nights of sleep thinking about my beginnings in global health because I never got this lens. I never knew that this lens was important. For any future global health engagements, we should ask ourselves, what are the goals and objectives of my rotation? Are our engagements part of a vertical or horizontal approach? Is our collaboration sustainable? Is it a one-way transaction, or is there true mutual benefit? What do authorship rules look like? Am I going somewhere and doing a research project and I'm first author and nobody else there was even invited to participate or figured out if that's a priority for them to study? Are we working with a government or with an NGO? Again, not vilifying NGOs, but why? Is there a strong reason to do so? How can the engagement be set up with a more anti-colonial framework, learning what we learned about the origins of global health what do the decision makers look like, right? Are they sitting in the malaria forum in Seattle? Or are they actually on the ground understanding what it's like to fight said disease where they live? And are our partners' priorities integrated into the collaboration, right? Or are they applying for grants, from Switzerland? And because, an organization there says, we need to eradicate such and such disease in this way. Well, are we listening to the way that the folks on the ground there feel like it's best to eradicate the disease? And is there some way we can work together on that? So these are questions that I hope you will keep in mind. Certainly questions that I'm trying to keep in mind as well. And a lot of references, let's see. The ones in bold I highly recommend. My talk is largely based off Dr. Packard's book, A History of Global Health, and Farmer's and Kim and Kleinman's book. But a lot of great health economists here have written so much on this, and a lot of lessons to be learned there. So these slides will be sent to you, and I really appreciate your attention and your involvement, and I'm happy to take any questions you might have. Yes.
The challenges and I guess the finalize successes in getting antiretroviral therapy to the generic market, or are there other mechanisms currently in place to allow for I guess other drugs that may disproportionately impact global health issues to be fast tracked or enter, like allow production in other countries outside of like the branding?
Yeah, it's a great question. If you, just for folks who couldn't hear, essentially similar to what happened with Big Pharma's control over heart medication for HIV, are there similar kind of situations in today's world or efforts being made to try to not repeat that history? The first thing I'll say is, unfortunately, the history was repeated with COVID, right? So we don't have to go back 5 years to see that, the wealthy were the ones who got the vaccines first. And then beyond the vaccines, you ask about medications. You think about all the different medications that were approved for COVID. Those were not and still are not today available in a lot of areas that are resource deprived. You think about all the monoclonal antibodies for COVID that we have the luxury to give at UCLA. We can't give those in most of the countries in the world. So I wish that the lesson was learned. On a legal, political level, I know there has been a lot of advocacy and work on this to try and move medications to become generic faster, to decentralize the control of it, to allow more flexibility in patents on medication. And you can imagine that there's this, there's a struggle between the folks who want to get the credit and the money for having discovered said medication, and then just trying to pass it out as fast as possible in an affordable way. And so in the end, it all comes down still to money. But there is a lot of advocacy going on, yes. How much momentum does it have? Not quite sure, especially with the recent government's kind of priorities. I think it's much more capitalistic and less, we're not participating in decision-making on health with other countries with this government like we were in prior governments. And so I think that's going to make it a challenge for these next few years. Yeah. Thanks, Tracy.
Based on my understanding of the presentation, over the past 200 years or so, it's been like a constant growth in funding of global health, and it just continues to grow. Is this really the first time in modern history where there's been a big retraction in funding of global health in the US? And then will that cause like even more fragmentation within the space because private sector will have to step in and like more NGOs will be funded? Is that kind of one of the consequences that people see happening? Yeah,
absolutely. I think that's spot on. I can't think of another time in global health history where the trajectory has been massively changed. Saad, can you?
I think I think that's accurate, but what is really, yeah, putting that in a context, the last 25 years, we went from 0 to 100. I'm not even still nearly enough, but like it was an exponential increase in funding. And so up until the early 2000s, the amount of money that was going into what we call global health or international health was minuscule, like just a tiny amount. So the impact of this is felt a lot more difficult. But for those of us who are old, like there was a long time. If you meet anybody 60 or older that's been working in this for a long period of time, it's like it was meager pickings for a very, very long time. So I just want you to keep that in mind when you think about this.
That's a really important perspective. Maybe we were spoiled in the first couple of decades, but it really was a commentary of how much the world was starting to work together, and for all of its for all the negatives that I painted for you today about global health and its history, it's still been the most involved that people have been in trying to prolong and improve the conditions of folks' lives who otherwise may not have resources or are deprived from the resources to have a chance. We always want to do things in the best way, right? And so we're academics. The way I approach global health as a practitioner is still academic. And I think there's just so much more we can do with the money that's been given. But that perspective, I think, is really important. But yeah, I think your point is very spot on. That, I mean, think about all of the initiatives that have been defunded in the past several months. Who's picking up the slack? It's private donors. And while it's amazing that we're trying to reach out to individual philanthropists, they can't match federal government bucks, right? They can't match them. So that's one. And then two, you end up relying on that donor's priorities. And so very quickly, you're going to have this like reordering or ordering of what that donor feels like is necessary to fund. And the process of a large organization looking at this and figuring out what needs funding from an epidemiologic perspective, for example, that lens may not be carried as much. So, but yeah, absolutely. For the foreseeable future, we'll have to look out to private donors to fill this gap. Thanks for the question. Other thoughts? Try to end on a positive note somehow. It's a very like, oh no, it's my fault. Other thoughts or questions? Yeah. Of course, thanks. Thank you. I'm happy to hear that. I wasn't aware of it either, to be fair, earlier.
When you were talking, the first thing especially like with the vertical approaches, the first thing I thought about were clinical trials, especially when you brought up antiretroviral therapy, how a lot of those trials were conducted in Africa. And it was very interesting how you mentioned they were like the last ones to be able to have access is due to the high cost. So I guess my question is like, I kind of already know probably how you're going to answer this question. But I do think research is a very important component of global health. There are still a lot of neglected communicable diseases that are still out there that require a lot of funding for research. And then there's the flip side where the research can actually be used to or indirectly harm communities. So I don't know. I guess my question is what is your viewpoint on research and clinical trials and how it looks like in our modern landscape?
Yeah, absolutely. Thanks for the question. I mean, so research is a huge portion of this, and I don't really talk too much about that in the talk. So thanks for bringing it up. So much of the way that physicians practice medicine in places beyond their own home is based off of the data that they understand from their home country, right? Why? Well, that's where that person was trained. And two, you're completely right. The likelihood that there is as robust of a RCT in the place that they may be practicing is probably not as much, just based on money and resources and personnel, et cetera. So there's this huge risk of extrapolating something we learned that, hey, this works in this population with these people, and assuming that it's going to work in that population with that set of people. We are so finicky about assuming, just in the United States, that a study that was published in, on a certain population in, rural Tennessee would apply to an urban population in Manhattan, right? And sitting in journal clubs, we'll say, well, I don't know, if we can extrapolate this. I don't know if the study's externally been validated. And so how do we have the confidence that this is going to be valid in a completely different country? And so I think that's a very valid question. What I have seen over the past 15 years is that if you look at the studies that the New England Journal is publishing, there is a heck of a lot more studies that are global health oriented than they were before. And so that's a step in the positive direction. There are journals on global health that didn't exist before. And so I think the academics are catching up to this. But one of the things we have to be careful about is who's writing those papers, who's doing that research, who's funding that research. And one of the questions of reflection was, right, what do the people doing that research look like? What do authorship roles look like? Who's deciding what needs to be researched? And I think we really need to be mindful of that as we approach research in global health. And so if we are approached to join a research project somewhere, I think some of those questions from the last slide are ones that can be applied to that kind of an opportunity. Well, whose idea was this? Who wanted this research? Where's the money coming from? What are the authorship rules going to look like? And that's super important. And again, I didn't have much of a lens into that in my first few years of practice. And I would look frequently to literature from the United States to try and inform my practice in Malawi. And then with time, we realized that, first of all, there's a lot more literature coming out of Malawi. A ton of research comes out of Malawi, a ton, as well as the rest of the continent of Africa, right? And same with other areas in the world. And we need to really be analyzing our practice based on the trials from that region. As a quick example, the way that we give IV fluids in sepsis in the United States differs from the way I do it in Malawi. Because there was this really big trial that came out of Zambia that said, hey, if you flood people here with fluids like you do in the United States, you're going to kill them. You're going to cause acute respiratory distress syndrome. You're going to cause pulmonary edema. Because a population living chronically with HIV that is malnourished has some element of inflammation contributing to capillary leak. And they are more chronically dehydrated than somebody living in Europe. And so if you give them the standard 30 cc's per kilo, which is what I give an adult who's hypotensive with sepsis, they may not be able to handle that fluid. You're going to flood their lungs. Do you have a ventilator to back that up? No. One quick example of how applying research from one place can really cause harm in the other. And so that oath that y'all took recently, right, primum non nocere, is super, super applicable in global health practice. Yeah.
We're not going to have enough time to talk about research in low and middle income settings, but I'm glad you brought it up because it isn't part of this selective. But I'd be remiss if I didn't say two things. One, you are being primed to think as researchers as being part of a big academic medical center. You have to be very, very wary of the fetishization of RCTs, okay? There are ways to know things that are not dependent on RCTs, and you have to be doubly wary of the tendency in our history in academic medicine to perform RCTs where the arm is no standard of care versus something that you know already works, all the caveats that Faysal said, but there's a ton of controversy, appropriately so, and a lot of moral outrage about in Africa offering pregnant women their baseline standard of care when you already know that AZT works, right, to prevent mother-to-child transmission. So if you're being invited to participate in a research trial where you already know something works, I don't care if it's contextualized or not, and you're exposing people to something where you'd already know something works, you need to walk away from that. And we can talk about it in more detail, but that still happens, and it's deeply, deeply problematic. Okay, so when you hear about research and all this stuff, you need to dig deeper. And IRBs aren't always, particularly IRBs in the United States, are not always or even often primed to actually think through that, because they're coming at it, just like Faysal said, from the lens of what's the perspective from an academic physician here. Oh, the standard of care is nothing in Durban, therefore it's okay to expose these people to nothing when you know something already works. Does that make sense? Okay.
And just to add on to that real quick, that's why it's super helpful to partner with folks who are doing the research, because you need local IRB approval, right? If I wanted to go to Malawi and do a study, I need the approval of the Malawian IRB, and that's how it should be, right? And they can review priorities, ethics, et cetera, to make sure everything is above bar. Yes. For the recording.
Thank you.
Sure.
So I had a question about the policy side of things. So thinking about this year being one of the first years where like the US didn't have any delegation going to like WHO's annual World Health Assembly, and other countries had like over 100 people delegations. How do you think as like early career professionals in global health that would impact us being siloed from those conversations?
Yeah, that's a great question. Yes and no, because I think obviously participation in those fora is super important. A lot of times for coordination of care and setting of priorities, a lot of times priorities are set at those conferences, and then based on those priorities, the funding is assigned kind of sequentially in order. And so really what they're trying to do is the representatives are trying to go to these conferences, then go back to their own government saying, hey, we're going to align on this, this, and that. And so if we're not present there, we're just not aligning with other countries on what needs to be done. We're kind of aligning with our own priorities. So I think there's still a way to know what's being decided there and what's happening there. Reports are published all the time from major international health organization meetings and conferences so that we can stay up to speed on what's being discussed there. It would be helpful, of course, for our own politicians and representatives to have a seat at that table. But there's a way to access that information for hopefully an interim period where we're on purpose not going. Does that answer your question? Yeah. All right. Maybe time for one more question if there is one. Otherwise, okay. I really appreciate your all's interest in this and your attention. Thank you so much, and I look forward to seeing you all the next videos.